This presentation will focus on a novel technique for single-port robotic bladder diverticulectomy with an intravesical approach, then transitioning easily to a known technique of simple prostatectomy. The patient is a 68-year-old man with a known history of severe BPH, lower urinary tract symptoms, and very low-risk prostate cancer as described here. Most recent prostate MRI shows a large left-sided bladder diverticulum and a 79 cc prostate. He has an IPSS of 28, mostly dissatisfied quality of life, and a high PVR. Here you see an axial cut of the patient's prostate MRI with a clear view of the bladder and large left-sided diverticulum. We started the procedure with a suprapubic vertical midline incision to allow for docking the SP robot into the bladder. We used a small SP access port with 8 air seal assistant port within. Here you see the robot is facing caudally towards the patient's feet. Just within the opening of the diverticulum, we will incise and dissect the mucosa, as shown with the arrow. We then dissect around the diverticulum between the outside of the mucosa and the extraperitoneal space. In order to face the diverticulum head-on and minimize any awkward movements or difficult locations of the arms and camera, our robot horizon is rotated clockwise. The camera is in the 12 o'clock position with a monopolar spatula on the right and fenestrated bipolar arms on the 9 o'clock and 6 o'clock hands. The diverticulum is initially dissected off the bladder from the inside out. Here it is dissected layer by layer. We then grab the inside mucosa of the diverticulum with our fourth arm and continue to dissect the outer walls of the diverticulum. Once we are in the extraperitoneal space, we dissect the outer layers of the diverticulum off of the extraperitoneal structures, as you can see here. Once free, the diverticulum is then pulled out of the body and is left inside the SP access port. A hemostatic agent was sprayed into the extraperitoneal space to aid in hemostasis. We then turn our attention to the closure of the bladder wall at the area of the diverticulum defect. We closed said defect with a running 3-0 V-lock suture. A suture was placed initially at each apex and tied at the midline. The defect is now closed. We can then turn our attention to the simple prostatectomy portion of the case. The robot horizon is then rotated counterclockwise, as you can see here. The posterior, dependent portion of the bladder is now at the 6 o'clock position, as would be standard. On the top left corner, you can see the prior diverticulectomy surgical site. The simple prostatectomy is then initiated and completed without complication. EBL for this case was 200 cc's. Operative time of 4 hours 10 minutes and a 22 French 3-way Foley catheter was placed at the end of the simple prostatectomy. The patient was stable postoperatively and discharged post-op day 1 with a catheter after an uneventful course. At 2-week follow-up, the patient had a successful void trial in clinic, and at 3-month follow-up, he reported voiding very well with only mild urgency. Pathology from the surgery was negative for any carcinoma of the bladder or prostate. In conclusion, this video demonstrated a novel technique for robotic single-port diverticulectomy. It allows for increased versatility for awkwardly located diverticula, as the surgeon can easily manipulate their horizon. This intravesical docking allows for the surgeon to stay within the extraperitoneal space, helpful for patients with hostile abdomens avoiding intraperitoneal structures. Lastly, one can use the same intravesical access for combined cases, such as a simple prostatectomy. Thank you for watching.